Yeah, thank you. It's a pleasure to have this invitation. Thank you, Venky. I had no idea he was going to talk about these radiation protection systems, so it kind of fits in very well with some of the previous talks. And there's been some really interesting concepts presented this afternoon. I hope we have time to discuss some of them. So let's talk about bread and butter of what we actually do on a daily basis. I ain't moving forward. Can you move my slide forward one, please? So bottom line is, while they're doing that, is think about the visualization of what we do on a daily basis. That's radiation dependent at the moment. It allows us basically to see tissue. It allows us to navigate our catheters. But the navigation part of it is really separate. It's why people like basically the FORS system and the Centerline can allow you to visualize catheters by enhancing the catheter in some way, either by using light, which is reflected, which models the entire length of the catheter, or developing an electromagnetic field which allows you to track the movement of a catheter. But at the end of the day, to do all the completion things that you need, you're still going to need to be able to turn on the radiation. And the discussion point and the selling point with a lot of these techniques is decrease the amount of radiation that you're going to get. And when you think and juxtapose this to what we've heard about these new systems, if all of a sudden these are effective and you can massively reduce the amount of radiation, then where we're going to spend our money on to protect us will change dramatically and will have pretty important implications about how effective and whether commercially viable they actually are. So a number of different ways in basically which we can do this. And that was the example of the egg. The penalty is radiation, but if you can take that equation out of it, then ultimately the question is, what are we going to load up inside our hybrid rooms and where are we going to spend our money? And there have been a lot of very interesting technologies presented today. Not one mentioned the costs. And I can tell you the discussion in my house, I work in probably one of the wealthiest hospitals in the United States, and the current topic of discussion is don't let the lines cross. Now, what we're talking about that is that we get paid 21 cents and 121 cents in the dollar for commercial patients. We get paid 91 cents on the dollar for Medicare patients. And for the first time ever, I've been told, your service, vascular, has moved from being positive in contribution margin to negative in contribution margin. And I think this is a discussion that we're all going to have is about cost effectiveness. And if we're given a piece of money, where are we going to invest it in? And that will affect some of the technologies we've talked about. We are a CT scan dependent specialty. It makes the diagnosis of most of all the aneurysms you've said. We've increasingly introduced that into the operating field by fusion, which we all need to get our hands on. That allows us really to probably reduce the radiation dose and dye dose and allows us to navigate based upon what you saw with CYDAR or what all the big imaging systems are going to have. And then we follow up in many cases with CT scans. I want to say to you that we almost led the revolution in changing from 2D imaging to 3D imaging. The next step that you really got to be involved in is dynamic imaging. We work in the most dynamic environment that exists in the vascular system, particularly when it comes to dissections. And yet, we're still using static images. If you look in the bottom on the left side, you'll see a dynamic CT scan showing inflow at the L4 left-sided lumbar artery, balloons up through the aneurysm sac and goes out through L3. That's important information. If you're going to take out one of these, then you're obviously going to take the inflow vessel. Solving the problem of dissections will really depend upon us being able to solve the complex fluid dynamic environment that exists inside the beyond the septum, basically, and inside the false lumen. And if you look at something like this, as we ventured into the ascending aorta, well, you know, what size endograft are you going to put in that, Dr. Lumsden, where you see it goes from completely patent to completely occluded, all within one cardiac cycle. And so understanding exactly what's going on inside these lumens is going to be extremely important. So we've published a bit on dynamic imaging. And the nice thing is we talked a lot about dynamic MR. That's not easy. And you need people who are really interested in it. You can all do dynamic CT scan. And essentially what you're doing is shuttling that patient in and out. Choose the region of interest. If it's an end leak, do you care what's going on in the spleen and the liver and the kidneys? The answer to that is no. Focus the region of interest and the dye and the radiation in the area to target to getting a solution for the problem that you're going to get. And so what that essentially does is like a strobe, taking pictures with time, and when you put that together, this is what you see. The dye arrival times, this is just an angiogram, a dynamic angiogram done with the CT scan. Dye's coming down. You may see dye behind the neck there. That's not an endoleak, that's a renal vein. And you can tell that because of the delay. And then you can see dye blossoming up in the back, basically, of the endoleak, of the aneurysm sac. And when you put all this together, you can see dynamically where these flow patterns are, and when you reconstruct it in 3 dimensions, you can see that. So if I'm going to invest time and energy, this is probably the area that I'm going to invest time and energy in. The better this pre-op CT scan, the better the fusion that you're going to get. That's why you really want to optimize CT scan in order to be able to do it. How you do the fusion really doesn't matter. There are a number of different ways: 2D fusion, X-ray fusion. Cone beam CT, 3D. We think if we need real high accuracy, that's probably the best way to do it. What CYDAR does is does it in the cloud. And we tend to think we don't use CYDAR because we're using fixed systems, but we are thinking about building out a new room with the portable C-arm, and there's the kind of place where CYDAR may offer an advantage. And the other thing this kind of forces you to do is, what do I need? Now, a lot of places show you the entire aorta overlaid. That's ludicrous. You know, what it forces you into, what do I need to do in order to be able to complete this operation? I need to know where the lowest renal is, the bifurcation is, and to take off the internal iliac artery. The rest is noise which gets in the way of the visualization of the devices. And having some sort of standard, which we use, red is right. Now that may sound stupid, because how can you confuse right and left? But when you go off axis, an REO-LEO becomes very confusing. So we should, as a group, decide what the standardization in terms of how we're going to label the various different targets that we need to get to that. And here's a situation where you could dynamically see flow coming from the IMA through the marginal artery all the way back up into the IMA. And that fusion, that is a center line which is drawn from the access point in the middle colic all the way down to the inferior mesenteric artery. And that's done by our techs, and all I got to do basically is be able to follow the pathway. But you got to have a really good CT scan in order to be able to do that. You can also use this in open surgery. We spend a lot of time thinking about this in the endovascular world. You know, I think you're going to have visualization systems, and HoloLens is an example of that. I'm going to go back for 1 minute. But you can basically import and fuse on top of a patient who's laying on an OR table. You can see exactly where the renal arteries are. And maybe we can improve the outcomes from surgery by targeting the incisions and make it less big. So I've not used any of these 3 technologies. I'm very interested in them. And part of this discussion is, where do we invest in this? And so CYDAR, I've mentioned, we're looking at or thinking about it because we're about to build out a 4th room. You know, the discussion at the end of the day is, you want to wait till 10 o'clock tonight, Dr. Lumsden, to get in the hybrid room, or can we pull in a C-arm? And the C-arms have improved remarkably, you know, over the past 5 years. And so this is one of the advantages here. FORS is a very interesting technology because it essentially reflects light and lets you model the entire catheter. Hard to know exactly what that role is. And again, both this and Centerline, if all of a sudden we're putting egg or one of these other systems on a table, and radiation is not the main discussion point, question is, am I going to invest basically in these kind of technologies, which, much like when I was involved in catheter robotics, the advantage was you could potentially sit out of the radiation field. Maybe that's not going to be the main consideration in the future. So there's a number of different strategies. If I was going to focus on one, basically it is on learning how to do fusion. The big imaging companies do not teach you how to do that very well, and I think that's important. We need to invest in training our techs. And secondly, I think learning how to do dynamic CTs, where the bang for the buck is, actually won't cost you anything, just a little bit of time and effort and energy. Thank you for the opportunity to present.